Yes, ma'am, we are live now.
Okay. Good evening, everybody. We are happy to have you here for the webinar hosted by the IFS South Tamil Nadu chapter. We'll start with the prayer song.
கருவாக்கி உருவாக்கி எனையாண்டு காத்தருளும் இறைவா நன்றி. எங்கும் நிறைந்தோனே எல்லை இலாதானே, எங்கேயும் எப்போதும் என் குலம் காப்பவனே. நெஞ்சம் துணிய துணையாய் வருவாய், நேர்மறை உணர்வுகள் பெருகிடச் செய்வாய். உடலில் உறுதியை பெரிதாய் தருவாய், உனை உணரும் அறிவை என்னுள்ளருள்வாய். சுற்றமனைத்தும் காப்பவனே, செய்தொழிலில் ஏற்றம் தருபவனே, எடுத்த செயலில் வெற்றி கொடு, என் ஆற்றல் பெருகிட அருளை கொடு.
Yes, can you close this? Dr. Ramani, our patron, is not in town, so I take the privilege even to give the welcome address myself. I welcome every one of you who are interested in this topic and has been making yourself free to be here with us. I welcome the speakers, both Dr. Reshmi and Dr. Anantalakshmi. I should say they were very, very nice to accept my invitation and they were ready to give the talk in a very short notice. Though Reshmi has been doing this every day, she was very, very kind to accept it and do it. And this is what we practically do. So I'm happy to have you here. And it will be really useful to all the people who are ready to listen to you in their day-to-day practice, I believe. I welcome you, Reshmi. And Anantalakshmi again, she has been doing the semen analysis and telling us the reports every day. So she is also well versed in her topic and would be very, very useful to listen to her and follow everything so that it will help us in our practice on the day-to-day procedures. Thank you very much. And I welcome Dr. Reshmi to start her talk. Dr. Reshmi is MS, DGO, DNB, and MS and holds a fellowship in reproductive medicine. She is in charge and is a senior consultant of reproductive medicine at Kinda Women's Health Hospital. I can't see it. Oh, she went off to her presentation. I can't see her CV. Yes, thank you. I'll introduce you, Reshmi. You can do your talk after that. Okay. Kinda Women's Health Center is where she works. She's a visiting consultant to Arvind's Hospital at Ponkulam, Indian American Hospital, Vaikom. She's a very, very sweet person. I met her last time at the ISAR conference, Kerala, and she was very, very nice. So I thought we should learn more from her. That's why I wanted her to talk on induction of ovulation. And we hope to listen to you, Reshmi. Thank you. Move on to your slide presentation. Thank you.
Thank you, Chitra Madam, for the kind introduction. And thank you, IFS South Tamil Nadu chapter, for inviting me for this your webinar. And it is my privilege to be presenting here in front of all the experts of Tamil Nadu. Warm greetings from Kerala. So, shall I move on to my topic, Madam?
Yes, madam, you can move your topic, madam.
Okay.
Yes, please carry on.
So the topic allotted to me is ovulation induction in non-ART cycle. Okay, let's move on to the basics. Just a few cycles on the menstrual cycle. So we all know that during the follicular phase, due to pituitary FSH, follicular recruitment, selection, and dominance happen. And the dominant follicle will secrete estrogen, which will cause a negative feedback effect on FSH and a positive feedback effect on LH, which cause ovulation. Post ovulation, the corpus luteum will continue to secrete progesterone. So, it is divided into three phases: recruitment, selection, and dominance. The recruitment happens during the first 4 days, selection during the 5 to 7 days, and dominance by day 8 of the menstrual cycle. So, once LH surge starts, ovulation happens in 36 hours, and the peak of LH surge is reached within 24 hours of its onset. And from the peak of LH surge, in 12 hours, ovulation will take place. So this is the basics which we all know. The sharp surge in LH with simultaneous increase in FH is what causes ovulation. And during that time, meiosis 1 resumes and the oocyte and the surrounding cumulus breaks away and are extruded, and the oocyte passes into oviduct. So we need to know who requires ovulation, when to do ovulation induction, how to do, and what are the techniques that can be used for this ovulation induction. Does all patients who comes to our clinic need ovulation induction? Let us see about that. So these are the common indication. WHO group 2, those women who are having anovulatory cycles, luteal phase defects, unexplained infertility, PCOS, and controlled ovarian hyperstimulation in ART, superovulation in IUI, hyperprolactinemia, and in poor responders. We all know that in female infertility, ovulatory disorders form around 40% of the patients, and out of the ovulatory disorders, PCOS dominates. So, ovulatory disorders are one thing that we commonly encounter in our day-to-day practice, and we need to know how to induce a proper ovulation in a patient. This is a WHO classification. WHO has divided ovulatory disorders into three groups. Group 1 constitutes around 10% of the patient who are hypogonadotropic hypoestrogenic. That is, mostly the patients with hypothalamic or pituitary failure. Group 2 is the predominant one, which constitutes 85%. They are normogonadotropic, normoestrogenic patients, mainly PCOS. And group 3, this constitutes around 5%. They are hypergonadotropic, hypoestrogenic group, that is mostly ovarian failure. Now, what are the drugs which we have in our hand for a proper ovulation induction? We use oral agents, injectables, and adjuvants. The oral agents that we usually use are selective estrogen receptor modulators and aromatase inhibitors. And in SERM group comes clomiphene citrate and tamoxifen, and aromatase inhibitors are letrozole and anastrozole. Among injectables, HMG and FSH, both are used according to their need. And the adjuvants that we commonly use are metformin, myonistal, N-acetylcysteine, and dexamethasone. Now, what is the role of ovulation induction? The role of ovulation induction is to increase the FSH above a threshold which will rescue a follicular cohort before they undergo atresia. Hence, more number of follicles will reach the pre-ovulatory stage. Now, one size fits all. This doesn't apply to our field of infertility. Which drug to use depends on the underlying cause of anovulation, the efficacy, cost, risk, potential complication associated with each medicine should be considered. And sadly, ovulation-inducing drugs are one of the most misused drugs, as you all might be seeing in your daily practice. But as fertility specialists, ovulation induction drugs is to be used only for a maximum of 12 months in a patient's lifetime for a maximum of 6 months consecutively. We have to strictly adhere to this principle while treating a patient. The goal of ovulation induction is the development of a single dominant follicle. Now, are there any prerequisites for that? A history and physical examination of both partners are essential before we move on to this. Evaluation of male partners, semen analysis have often seen that semen analysis are not always done, but it is mandatory to do a semen analysis before we give this ovulation-inducing drugs to the female partner, because the male may be having a severe oligoacidotetrospermia while we may be overloading the wife with a lot of drugs. So we have to convince the man that it is just a test, you just get it done. If it is okay, let us move on to ovulation induction. Relevant blood investigations are thyroid function tests, CBC, RBS, prolactin. We routinely don't do pituitary function assessment, only when we are in doubt of diagnosis. For example, if a group 1 patient comes or a group 3 patient comes, if we are suspecting such a patient only, we may need to do an FSH, LH, estradiol level, etc. So, coming to clomiphene citrate. Clomiphene citrate is the most commonly used selective estrogen receptor modulator, which exhibits both agonistic and antagonistic activity. An ideal dose is 50 to 100 milligram from day 2 or 3 of the cycle for 5 days. And can we increase the dose more than 100 milligram? Mostly, we usually restrict to 100 milligram. Those studies says up to a maximum of 150 milligram may be given, but then we all know that that may cause a lot of hypoestrogenic effects in the female, like thin endometrium, thick cervical mucus, etc. Clomiphene citrate does not appear to increase the chance of pregnancy in a woman who ovulates regularly but fail to conceive after 1 year of unprotected intercourse. So these are the unexplained infertility category patients. So simply giving a clomiphene citrate to a regularly ovulating woman, it has to be thought about. Now, what does clomiphene citrate do? It causes irreversible inhibition of estrogen receptors at the hypothalamus, which will increase the level of GnRH and FSH, because the negative feedback effect of estrogen is not happening, and this will induce ovarian follicular development. So during clomiphene citrate, the levels of FSH and LH undergo prolonged rise because of the prolonged estrogen receptor depletion in the brain. That is, the FSH window is extended, and this is the factor which leads to the multiple follicular recruitment. So we'll see how it differs from aromatase inhibitors. So in a normal ovulating woman, what happens when we give clomiphene citrate? It will increase the GnRH pulse frequency, while in an anovulatory woman, although already the pulse frequency will be high, in that category, the pulse amplitude is the one that increases. Is monitoring required? In my opinion, whenever we give a clomiphene citrate, because of the risk of multifollicular ovulation, we have to always do a monitoring. Follicular study is a must. A transvaginal ultrasound, which we all do, we have to make the patient do a follicular study, because letrozole usually causes monofollicular ovulation, but we give clomiphene citrate and letrozole in different patients. So those patients whom we are giving clomiphene citrate, we need to do a transvaginal ultrasound and a follicular study. A baseline scan on day 2nd or 3 is done. Thereafter, from day 9 to 10, we do a repeat scan depending on the number of follicles which are developing. And if 3 or more follicles are developing, we have to have a low tolerance for cancelling that cycle. So we should not feel that, oh, this patient has come to us and how can we cancel the cycle? So there is a very high risk of ovarian hyperstimulation syndrome, especially if we are doing a ovulation induction with clomiphene citrate and more than 3 follicles are developing. So there are two risks, OHSS and multiple pregnancy. So we can always counsel the patient and cancel the cycle if such a situation arises. But what are the drawbacks? Clomiphene citrate, as we all have experienced, have a very high ovulation rate of around 80%. But that doesn't convert to pregnancy. The pregnancy rate always hovers around only 10%. There is a risk of multiple pregnancy, thin endometrium, and anti-estrogenic side effects, which may be detrimental to embryo implantation. As I've already mentioned, there is a risk of ovarian hyperstimulation syndrome. The effect may last longer. The half-life of clomiphene citrate is high, so which may lead on to luteal phase defect. And premature LH surge may occur due to supraphysiological estrogen level. And it cannot be used in hypogonadotropic dysfunction that we already know. So these are the other adverse effects that a patient may experience, like irritability, vasomotor symptoms, abdominal and breast discomfort, etc. Now, some other facts. Clomiphene citrate, along with dexamethasone, have been found to cause significant improvement in ovulation, especially in clomiphene citrate resistant cases. So this has worked a lot of times for me too. Significant increase in pregnancy rate in clomiphene citrate cycle when pre-treatment with OCPs have been done rather than CC alone. If ovulation does not occur, then the dose can be increased by 50 milligram to each subsequent cycle, but not to go above 100 milligram. Alternative medication approaches are recommended if more than 150 milligram are to be used. So, not more than 6 cycles continuously and not more than 12 cycles lifetime. This is to avoid the risk of possible malignancy. And this is what is recommended by RCOG. And GPP in RCOG and NICE guidelines also recommend to monitor the ovaries during stimulation with clomiphene citrate. So it is what RCOG and NICE guidelines also recommend. Now, two terminologies. What is CC failure and what is CC resistance? CC failure is failure to conceive within 6 cycles of clomiphene citrate induced ovulatory cycles. That is, with clomiphene citrate, a woman is ovulating, but still she is not conceiving. This is a clear indication to expand the diagnostic evaluation. So she may be having infertility due to some other factors. Ovulatory disorders may not be the only cause for her infertility. We may have to again evaluate the male partner or tubal factor or uterine factor. And this is a time when we have to change the overall treatment strategy when evaluation is already complete. Now, what is CC resistance? So we see CC resistance in around 20% of the patients. That is failure to ovulate even with high doses of CC. So usually occurs when it is associated with insulin resistance. Now, coming to aromatase inhibitors. What does aromatase inhibitor do? Aromatase enzyme converts androgen to estrogen. So an aromatase inhibitor blocks this conversion, so the androgen level increases. And there is also decreased negative feedback from estrogen, which causes an increased FSH from the pituitary. Accumulation of androgen locally may increase the follicular sensitivity to FSH. So increase in androgen level and decrease in estrogen level. That is what happens in aromatase inhibitors. The recommended dose is for 5 days, day 3 to 7, 2.5 or 5 mg can be used. There is usually monofollicular ovulation, which will, because the pathway is still clear, that is, the estrogen feedback mechanism will take place. So monofollicular ovulation will take place, so reduced chance of multiple pregnancy and OHSS, reduce adverse effect on endometrial and cervical mucus. And pregnancy rates almost similar, though letrozole appears to be safer than CC. Now, we all know that there were initially some teratogenic potential concerns regarding aromatase inhibitors, but surveillance studies do not demonstrate a higher rate of congenital malformation. And the early timing of administration also reduces the fetal exposure. Now, CC has been the first line of treatment with proven efficacy. But letrozole is replacing CC as a first line, especially in PCOS causing monofollicular ovulation. Letrozole does not deplete the estrogen receptors in the body and it has a shorter half-life. Now, these are certain other protocols like extended letrozole protocol. So we usually see that when we give 2.5 mg for 5 days, a lot of patients, especially obese PCOS with insulin resistance, don't respond. So in these patients, we can consider an extended letrozole protocol with 5 milligram per day, which can be extended to 7 to 10 days. So the latest fertility sterility article by Zhu et al., which was released in 2022, has claimed a 90% ovulation with a 30% pregnancy rate. But one thing while using this protocol we have to keep in mind is, so letrozole is always, we have always learned that there is a risk of congenital anomaly. So what will happen if we are giving it for 10 days? Are we increasing the exposure to the fetus? That is what we have to keep in mind while giving the extended protocol. Now coming to the stair-step protocol. So stair-step protocol was already being used for clomiphene citrate. So this has recently, in 2019, Thomas et al. Used this protocol with letrozole. So here what we do is 2.5 milligram letrozole is given for 5 days. We monitor the patient after 7 days of the last dose. If we don't see any dominant follicle, we increase the dose to 5 milligram for 5 days. And again, we monitor with ultrasound after 7 days. And if needed, we give a dose of 7.5 milligram for 5 days. Here also, there's a prolonged exposure to letrozole. But this protocol eliminated the use of progestin. So what we usually do when we see that 2.5 milligram 5 days, a patient is not responding. In 12 to 15 days, we do an ultrasound. Then we give a progesterone withdrawal and ask the patient to come for the next cycle. So in this protocol, we are doing everything in the same cycle. We don't have to wait for 3 cycles for ovulation induction. But again, this is a recent study. We have to again consider what will be the effect of letrozole on our fetus. Now, step-up protocol. This was reported by Mitwali et al., where step-up doses of 1, 2, 3, 4 tablets were given on days 2, 3, 4, 5 of our cycle. So on day 5, a patient will receive 4 tablets of, that is 10 milligram letrozole. So this study had a very small sample size, but I'm just mentioning this for completion's sake. And this, according to that study, there was a higher pregnancy rate was shown when compared to CC. So, do we need gonadotropins for a routine ovulation induction? Not in all cases, but in some patients who are not responding to CC or letrozole, we may have to resort to gonadotropins. The gonadotropins, as I've already told, which we usually use are HMG, FSH, or FSH plus LH. We have different regimens for use. I'll just show a slide. A step-up protocol when we start with 75 units daily from day 2 or 3 of the cycle. On day 7, we do an ultrasound. And if there is no follicle, no dominant follicle, we increase the dose by 50 or 100%. That is, we can increase the dose plus 37.5 or we can increase the dose to 150. And again, we monitor till a dominant follicle of more than 17 mm develop. This is a low-dose step-up protocol. This can be done in a PCOS patient when we start with a very low dose of 37.5 and again scan on day 7 and increase the dose by 50%. This is a step-down protocol where the initial starting dose is around 150 international unit, and once we see a dominant follicle rising of around 10 millimeter on day 4 or 5 of the gonadotropins, we can decrease by 37.5, and then again, once the dominant follicle is more than 18 millimeter, HCG can be given. Now, there's a standard protocol when the dose is kept same throughout the stimulation. The use of agonists or antagonists are usually not recommended in ovulation induction or IUI cycle. So we talked about gonadotropins, but the use of agonists or antagonists are not recommended. Whether to use urinary or recombinants, it all depends on the discussion of purity and cause. So there's no convincing evidence of significant difference between the two. Now, this is one protocol which we Indians love. That is a sequential CC or letrozole and gonadotropin therapy. Why? Because this will give us the same benefit of total gonadotropin therapy along with a decreased cost for the patient. So we usually give a standard dose of CC treatment followed by a low dose HMG or FSH of around 150 international unit for 3 days. The treatment is individualized in the same way as the traditional therapy on the basis of transvaginal ultrasound. The sequential CC-HMG is as effective as HMG regimen for ovulation induction and produce satisfactory pregnancy result with decreased treatment cost. Now, how much to give? That is our second question. So I think I've already mentioned that the dose depends on the age, BMI. BMI is very important. Ovarian volume, antral follicular count, and AMH, FSH if we have already done that. Now, a few words about the adjuvants. Metformin alone compared with placebo has been found to increase the ovulation rate in PCOS, but it is not to be used as first line for ovulation induction. It increases the live birth and reduces miscarriage rate in women undergoing ovulation induction, but at present recommended only in women with impaired GTT with increased fasting insulin. Now, coming to N-acetylcysteine, this is a mucolytic agent, is effective in inducing and augmenting ovulation. It's usually used along with an ovulation-inducing agent at a dose of around 1,200 milligram per day. It inhibits oxidative stress and improves peripheral insulin. So, is there a role of minoxidil when we have metformin? Many times, what I've seen is many women are not able to tolerate metformin because of the severe gastrointestinal side effects. So, in that group of women, we can definitely consider minoxidil, especially in women with PCOS with insulin resistance. Now, a few words about IUI since we are talking about non-ART cycles. So, why IUI has to be coupled with controlled ovarian stimulation? Can we do IUI in natural cycle? Of course, we can do IUI in natural cycle, especially in women with male factor infertility or a cervical factor. But in other factors of infertility like unexplained or ovulatory dysfunction, IUI has to be coupled with COH because it provides more number of oocytes for fertilization and implantation, and we can time the HCG injection and we can predict the ovulation better so as to do the IUI near ovulation. The controlled ovarian hyperstimulation corrects the subtle endocrine defects which impair ovulation and implantation. So these are the few studies. So mild stimulation of 1 to 2 follicle, it is said to reduce the cost and multiple pregnancy rate, but this may require more cycle of treatment. But that is a study which was published into Human Reproduction. But what I personally feel is that more than 2 follicles, better not to go ahead with IUI. Cancel the cycle. In women with ovulatory dysfunction, letrozole was associated with an increased pregnancy rate and as a similar pregnancy rate compared to CC with a significant decreased rate of multiple pregnancy. So letrozole and CC both have similar pregnancy rate, but as I've already said, letrozole is found to be safer. Shifting from unifollicular to bifollicular IUI cycle potentially increase the chance of achieving a pregnancy by 3.4-fold. So that is something which is desirable. 2 follicles in IUI. Now, what is an optimum IUI stimulation? 2 to 3 follicles of 18 to 19 mm with a good endometrium of 8 to 14 millimeter trilaminar pattern, and IUI is usually done after 36 to 40 hours of HCG injection. Usually, we can use a dose of 5,000 or 10,000. Now, a few concluding points. Clomiphene citrate is still the first line of drug for ovulation induction because clomiphene has been with us since ages. For PCOS, aromatase inhibitors are an effective alternative due to lower cost, ease of use, and monofollicular development. And Controlled ovarian stimulation IUI is preferred over natural cycle, and this should be our dictum: never induce more than 6 simultaneous cycles and never more than 12 cycles in a woman. Thank you.
Thank you, Dr. Reshmi. That was wonderful.
We have a question in the chat box.
Yes. All the questions can be on the chat box so that we can ask her.
Yeah.
Yes. Ask the question.
Dr. Reshmi, the question is, which letrozole protocol will be best for multifollicular development?
So usually letrozole is for unifollicular development, and then I usually do is 2.5 milligram ED for 5 days in a woman whose BMI is normal.
Okay, so the regular protocol itself.
Yeah.
Okay, that was the only question in the chat box for now. So if there are any other questions, please put it up. Otherwise, we'll go on to the next topic. I'm very happy to call upon Dr. Ananthalakshmi to give the next speech. She's a certified reproductive embryologist from the American College of Embryology with the highest score in exam in ever. She's the first Indian honored as the Embryologist of the Month by EMBCOL. She's also a member of the practical committee in American College of Embryology, SHA certified clinical embryologist, and she's got a lot of other medals and accolades to her credit. She is also a faculty in embryology in the Indian Council of Obstetricians and Gynecologists certificate course in reproductive medicine, an active researcher and member of the Global Andrology Forum, and many more. She is also the recipient of the ESAR Rising Star Award 2023. We are very happy to have you with us, Dr. Ananthalakshmi. Over to you.
Thank you so much for the kind introduction, ma'am. So the topic of discussion today is going to be on sperm preparation methods. So conventional versus newer methods. So nowadays we are in the market, there are so many newer devices available for sperm preparation. So I'm going to throw some insights on that after concluding with the conventional methods. Is my screen visible?
Yes, doctor.
Thank you so much. So to start with, how to get a good sample for insemination. So this webinar is on non-ART cycles. So I also tried to conclude the sperm preparation methods which will be useful for IUI. That is intrauterine insemination. When you take IVF and ICSI, you have so many methods. And even if you get a low number of sperms, we can use that for ICSI. But it is not so with IUI. For an IUI, to get a better results, you need at minimum of a post-wash more than 10 million per ml. So this is going to cover the conventional method versus newer methods. So why should we actually prepare the spermatozoa before or the semen before insemination? Normally, the fertile spermatozoa get separated and swim up through the cervical mucus. During the process, the capacitation will happen. So what as such the capacitation means is, it is the efflux of cholesterol from the plasma membrane. Initially, when people who don't believe in a direct swim up, they claim that capacitation will be facilitated only by the centrifugation. Because of the spin which we are giving that promotes capacitation is the concept of centrifugation initially. But nowadays, direct swimmer has come up with a, and this microfluidics technique has also, without centrifugation, is giving good results. So to move on into the topic as such, why should we prepare the semen sample before an IUI? Normally, we are trying to mimic the condition which is happening in utero as outside the body. In vitro, we are trying to mimic the same. So in order to yield a highly morphologically good spermatozoa and to prepare the sperms without debris and non-germ cells and the round cells, we are trying to prepare the spermatozoa semen sample before insemination. And also the semen sample will contain prostaglandins, which may promote uterine contraction and produce severe cramping to avoid this, we have to prepare the semen sample. So coming to the method of preparation, what is the ideal method? Any method which we are adopting should be quick, easy, and cost effective. And this method should be easily for adaptable, and also it should isolate as much as motile spermatozoa as possible. And it should not cause any DNA damage. When coming to centrifugation, we usually will be worried about the DNA damage which is caused by the centrifugation and the ROS which is being increased in the sample. So we should avoid that, and we should eliminate the round cells and the other debris. And the method which we are choosing should allow us to process a large volume of ejaculate. Some person may give you 4 ml of sample or 5 ml of sample. So the method which you are going to adopt should accommodate all the volume of the semen sample to process. So coming to the culture media which we are going to use, you can use any culture media which is HEPs or MOPS based buffer. When you're having a normal incubator in the andrology, some labs may be without incubators also. So as an embryologist, I prefer using an incubator in an andrology lab. Mere using of test tube warmer may not be sufficient for a lab, because when you are using incubator, it will be maintaining the temperature all throughout the sample, all throughout the procedure, and all the 360 degrees will be covered with the same temperature of 37 degrees. So when you use an incubator, dry incubator in your lab, you can either use HEPs or MOPS buffered and media that can easily simply maintain the pH at 37 degree. Suppose if you are sophisticated enough, you're using an IVF lab nearby and you're having a separate CO2 incubator for that sperm preparation alone, you can obviously opt for an CO2 incubator and bicarbonate-based buffer media for preparation. So obviously, when comparing the both, it's not the results of the sperm recovery is not very much different between the two. Just to use, you choose either of the media. Coming to the choice of the method, it depends on the nature of the semen sample. Actually, you cannot ideally say this is good for everybody. Like that, you cannot choose any method. So you have to choose the method of preparation according to the nature of the semen sample. So when you are getting an ormozospermia semen sample, you can opt for swim up, which is a simple and easy technique. When it comes to an abnormal semen sample with more of round cells and virally infected sample with seropositive samples, you always go for a density gradient with another wash, and also swim up will be better. Followed by density gradient, you have to allow the sample for swim up. That will be better option. So coming to the method as such, the direct swim up is a conventional, very easy method where you're going to take the semen sample in the test tube and you're going to overlay the sperm wash media of 0.5 ml over the semen sample which you have taken in the tube. So you have to keep the tube at 45 degree in order to increase the surface area, so that you will be having more number of spermatozoa getting swim up there into the culture media. So with this, when you're keeping a rack like this and maintaining it a 45 degree angle, always it will be better to use an incubator here. In the test tube warmer, you can keep the tube only in a straight upright position. So this is the method of direct swim up. If you have certain advantages and disadvantages in this too. So as I said, it is easy to perform, cost effective, no technical expertise is needed. You can simply, clinician by herself can do this. And you can also get a good clear fraction of highly motile spermatozoa in this. So here, when we are talking about DNA damage, centrifugation must be avoided. We have to try to reduce as much as speed and the time limit for centrifugation as much as possible. So when that is concerned, direct swim up offers you highly motile spermatozoa without any centrifugation. So ROS is less, DNA damage is less. So coming to the disadvantages, when you allow a large volume of semen sample being processed in this method, you can actually have other debris and immotile spermatozoa getting brought along with the motile spermatozoa to the top layer. So you might not have a very good clear fraction free from debris. That is the disadvantage. So for this, we have moved on to simple wash or pellet and swim up method. Here again, same thing, you're going to take the semen sample, again overlay with the sperm wash media. Here you're going to wash the semen sample. So you have to take equal amount of semen and equal amount of sperm wash. You should not use less amount of media here. because it is going to wash all the debris and remove the seminal plasma from the sample. So when you take 2 ml of semen sample or 3 ml of semen sample, add adequate volume, that is equal volume of sperm wash media to that, and subject the sample to centrifugation for around 300 to 500 G. When it comes to RPM, it is 1500 RPM for 10 minutes. So after that, the supernatant will be separated and discarded. After that, you're going to overlay the sperm wash media of 0.5 ml over the pellet, which is collected at the bottom. And this is allowed to another swim up for around 45 minutes at 37 degree. So this after 45 minutes, you can take the sample and the supernatant will be having the motile fraction, and that can be used for insemination. So can we use this for all? Again, it is also an easy method, but compared to DG, you no need a density gradient media. You just need the sperm wash media. So it is cost effective, and it also clears the debris which we get in the direct swim up method. Here you will not get any debris as you are using one centrifugation. So disadvantages, again, we are worried about the centrifugation which may damage the DNA. So with this question in my mind, I searched the literature and I found this article which compares pellet and swim up and the swim up technique which involves centrifugation and without centrifugation. This study states that there is no extra DNA damage compared to direct swim up and the pellet in swim up. So you need not worry about the centrifugation and you can go ahead with. So next is the conventional method, which is density gradient method. You have two different types of density gradient media available in the market. You can use either single gradient or double gradient. It is 80% or 40%. Some companies are providing 45% and 90%. Anyway, you're going to take the 80% gradient in the bottom of the test tube. Above that, you're going to lay with 40% gradient, over which you're going to lay the semen sample. So here what you have to take care is about the volume of the semen sample. Totally, you will be having around 2 ml to process here. Density gradient media will be around 2 ml, 1 plus 1. So over that, you can overlay up to 2 to 3 ml of semen sample in the same test tube. Suppose if you have more volume of semen sample, you should take another test tube and split the sample into two. So without that, if you overload the semen sample over this density gradient media, you may not get a clear fraction of motile spermatozoa as given in this picture. So after centrifugation, you are going to subject the tube for centrifugation around 2000 RPM, that is 300 to 500 G, another for 20 minutes. It is the textbook or the literature evidence. You can decrease the speed and the time limit for centrifugation according to the nature of the semen sample. So when you, after centrifugation, you will get a fraction like this. The motile spermatozoa will be separated at the bottom. Above that, your non-motile cells and the debris will be separated. So after this, you are going to discard the supernatant and you are going to subject the sample along with sperm wash media for another centrifugation of 1500 RPM for 10 minutes. Again, this also can be adjusted to 1300 RPM. And for instead of 10 minutes, we can decrease up to 7 minutes. So when you get a severely actinozoospermic sample, so you can decrease the centrifugation speed, because when you give more and more centrifugation, it is going to affect your motility too. So after this second step of centrifugation, you will get a clear pellet like this. You can directly mix this and use it for insemination, or ideally you have to allow the pellet and you have to add some of sperm wash media of around 0.5 ml. You have to subject the sample for direct swim up, which again gives you a very clear fraction without any immotile spermatozoa. So for density gradient method, ideally it should happen. We will get around 20 minutes for liquefaction, another 20 minutes for first centrifugation, another 10 to 15 minutes for second centrifugation, and direct swim up for another 45 minutes. So around 1 hour, 1.5 hours to 2 hours you might need for preparation. So it will take a quite long time. That is one of the disadvantage. But when you compare the clear fraction, it will be very clear compared to all the other methods, as it is being separated using the density. So here the leukocytes, all the debris will be eliminated to a larger extent. And the media, compared to cost, it is little bit expensive than your sperm wash media. And reactive oxygen species is reduced compared to other methods, but it is still present. So this is a comparison table involving the centrifugation and the spin time, everything. So the processing time will be more here because here they have given because of they didn't involve the direct swim up after density gradient. So it is the processing time is given less here. Compared to cost, density gradient gives you more cost, involves you more cost. So when after post wash, taking out the post wash, how will you know your preparation is right? So you have to calculate total motile sperm concentration. Actually, how to calculate this? You have to multiply your sperm concentration into volume of the semen sample into total motility is maybe the right option. But when you do a progressive motility here, suppose your concentration of semen sample is 15 million, volume is 3 ml, it is around 45 million. So out of that 45 million, if you are having 50% progressive motility, which includes fast progressive and slow progressive. So 45 half, around 22 million should be your post wash. But when you get more than, you can also get more than 25 million, 22 million like that. If you get that sample as 22 million, it is correct. Anything more than 22 is correct. But when it is less than 22, your method or you are missing the sperms somewhere else, or you're leaving some of the motile fraction over the pellet, that could happen in some of the samples. So after every post-wash, you have to calculate this total motile sperm concentration. So how can you maximize your yield? That is the post-wash. Is use the media at 37 degree. Somebody will rotate the media with the hands for a few minutes, for 5 to 6 minutes, for 5 to 10 minutes, and then they will start preparing the spermatozoa. That is not so. You have to incubate the media properly at 37 degree. For this, at least you can use your incubator or test tube warmer. So this will protect the spermatozoa from cold shock. And when you're using any bottle of media, or nowadays we are getting a disposable packs with single use for 1 ml, 1 ml and 5 ml of sperm wash. If you use a particular pack for that patient, the remaining media should not be re-incubated and used for the second patient. If you want to use that, you have to take the particular fraction of the media and you have to incubate. You should not take the whole sample and incubate, then you cannot keep it inside the refrigerator. So when this happens, it can decrease your efficiency of sperm preparation and the media can appear cloudy or hazy due to growth or some other infection in that media. So you should not use the same pipette for more than one bottle of media, or mixing of the semen sample pipettes with the media is also not permissible. So coming to highly viscous semen sample, we'll usually come across with this highly viscous semen sample often in our IVOA preparation. So for this, we are having some inert substance called collagenase, which is available in the market. You can mix that inert powder and you can subject the sample for semen preparation. So that will decrease the viscosity, and after that you can get a good yield of spermatozoa. Without doing that, when you try repeated syringing, and even after repeated syringing, if the viscosity is high, you cannot get a good yield, and you cannot take out the properly. The pellet will not be also formed. That is the problem. So coming to another point, I told you avoid overloading of the gradient. So you should not overload too much of semen sample over the density gradient media. And ideally, the insemination time should be as soon as the sperm preparation is ready. So ideally within 90 minutes. So when you use density gradient followed by swim up, this is not possible. But try to inseminate as soon as the sample is ready, because the capacitation, premature capacitation will affect your results. So as soon as the sample is ready, the insemination should happen. And one more thing, comparing the different efficacy of different methods, that is sperm preparation with density gradient, swim up, and pellet and wash. This Cochrane review has found no difference between the three different techniques. And some of the studies included in this review didn't report any live birth. So it is we cannot conclude based on this. But as the ongoing pregnancy and the clinical pregnancy rate is concerned, this study didn't found any difference. Coming to the newer methods, which is magnetic assorted cell sorting, you know that it is based on annexin B exposure. That is, it is a apoptotic marker which is expressed on the cell surface. So this will be detected and the apoptotic sperm will be separated from the non-apoptotic sperm. And we will be taking out the non-apoptotic sperm which is present in the center. So the major disadvantage is you have to subject the sample for density gradient. After density gradient, you have to put inside this magnetic chamber and they will be giving you the beads. You have to follow the company's protocol, and the magnetic beads will attract the apoptotic spermatozoa and non-apoptotic sperms will be in the center. So this you can take out with a syringe and use for insemination. So again, IUI we can try max, but the time you require for DG, again it is more. After DG, you have to subject the sample for max. So you need more time, and the chamber, which is a magnetic chamber, which is required, and the kit which is available for each sample is also very costly. So this has not come in a big way for IUI preparation. One reason is time and another reason is cost. So you have to involve both the methods, and we don't find any studies which is supporting MAC for an IUI results. And we have come up with many newer techniques like microfluidics. So MAX is considered to be a little bit outdated regarding IUI preparation. So coming to the newer method, that is microfluidics, you have the opportunity to sort the sperm cells faster and a gentler way without any centrifugation, which the process which mimics the natural selection. So here the laminar flow is the basis for microfluidics. Here we are going to manipulate the fluids and suspended particles based on the fluid deterministic behavior. So here you have selection based on chemotaxis, thermotaxis, and rheotaxis. Chemotaxis is the chemical gradient, thermotaxis is the thermal gradient, and rheotaxis is based on the positive flow against the swim up against the flow. So in this microfluidic device, you will be having a channels like this of a particular dimension which allows the laminar flow for the spermatozoa to swim up. So here you can see so many outlets. Here the motile fraction will be separated and the debris will be separated in the other outlet. So this is the as such basis for microfluidics. Nowadays in markets, we have so many devices available which claim that as a microfluidics. So we have to think twice whether it is actually working in the principle of microfluidics or not. I'll explain that in the future slides. So we have very few systems available for an IUI in microfluidics devices, which offer you more than 10 million as a post-wash. If it is available, it can definitely give you high 100% motile spermatozoa because it is separated based on the laminar flow. And again, coming to the morphology and DNA integrity, here we are not doing any centrifugation. It is a simpler method. So it is definitely going to give you morphologically better and DNA integrated spermatozoa. So this is a Qualis chamber, which was available in the market in the past years, but it is not frequently available nowadays. Here also, they claim that when the post-wash is more than 10 million, you can use it for IUI. But here, the volume which we are providing, the semen sample volume will be very less in microliters. That is around 850 microliters to 900 microliters, which we will be keeping in this inlet, and sperm wash media in the other inlet. After 30 minutes of incubation at 37 degrees, the motile spermatozoa will be separated to the chamber C, and immotile will be collected in chamber D. Actually, when it is available in the market, it was also claimed to be used only for ICSI, not for IUI. But later on, they have developed a device which can accommodate so much of semen processing, and the volume of the semen sample can be large enough to do the preparation. So this is one of the device which is FertiDish and not available as such in India, I think. We have Zymote available in India. But the paper which is published in IUI is about the FertiDish, which we can use it for IUI and we can get a post-wash of more than 10 million. And this is another device, this is Lengshook available in the market, which is again having a membrane filter, which is going to separate the semen sample. And after the filtration through the membrane, the sperm will be swimming vertically downwards as shown in this picture. And it will be swimming through the channel which is provided. After that, it will be collected in the outlet. From the outlet, you can collect the 500 microliter, that is 0.5 ml of spermatozoa. So this also gives you motile fraction. The point is, we are not using any centrifugation, easy to prepare, but the capacitation, we are not involving any centrifugation, as I said. So the capacitation, whether it is going to happen or not, we have to wait and see. And the results regarding IUI preparation, we have a paper in the upcoming slides. I'll explain that. This is a Zymote device. This also has a membrane filter, which is going to filter the semen sample, and the channels will be separating the motile fraction separately. So this is the study which is comparing the lens hook device and the density gradient method and other microfluidic sperm sorter. So in this study, they have not involved any patients, just they have compared the semen sample, used the semen sample from the patients, and they have compared the morphology, DNA fragmentation, and other uh, parameters like acrosome reaction, capacitation, everything in the upcoming slide. So coming to the results, in this study, they have compared the DNA fragmentation and the acrosome reaction. They have also calculated the peak velocity, curvilinear velocity and all. We still didn't find any conclusion whether it is very much useful, that curvilinear velocity and all, which are given by CASA. So I have not included here. So here they are saying that DFI after preparation is very low compared to DG. Zymote is also giving lower DFI, and the CA0, that is lens hook device, is also giving lower DFI. Compared to Zymote, even lens hook is giving better DFI, lower DFI compared to Zymote. Coming to the acrosome reaction, which we will be worried about the samples when we are using for IUI. So here they found that acrosome reaction is happening, and it is 6.5% in Zymote and 7.4% in CA0. Now you can see this normal acrosome reacted sperm is in DG is little bit high, and in Zymote and CA0 it's little bit low. So this we need not worry about the acrosome reaction when you are using the sample for an ICSI. But in IUI, the natural fertilization has to happen. So they are trying to modify their protocol with little bit of centrifugation, and they're trying to use the whole semen sample, which can be loaded into the Zymote device and the CA0 device. So this is the same study which is on non-normospermic sample. So always these devices will claim that they can be used only for normospermic samples, but here they have done for abnormal samples also. They also found that decreased DFI and acrosome reaction. So here they are claiming that this is capable of giving acrosome reacted sperm, but decreased in acrosome reacted sperm have been found with Zymote and lens hook device, but not in density gradient. This we have to wait and watch for their use in IUI. So they have established results in IVF cycles and ICSI cycles with egg donation cycles, and they found that embryo ploidy status is better when we use this device, and the blastulation rate is very good, and euploidy rate is very good when we use this device. So compared to Zymote and direct swim-up method again, this is also not on patients. They have just compared the motility, both the direct swim-up and the Zymote. It is found to be good. And this is also another study for microfluidics. Again, this is about IVF and ICSI, not for IUI. So for IUI, they have under research, a microfluidic chip has been tried with 130 washed semen samples. So they are trying to accommodate large volume of semen sample in that device. And this is under research, and it is not available in the market at present. So this is a study which compared microfluidic device with density gradient. This study was not about Zymote, not about lens hook. That we should remember. It is about a 40 chip device which is not available in India. So, as far as IUI is concerned, microfluidics, we have to do it with caution as a research procedure. My advice is to little bit change the protocol with involving a little bit centrifugation, where you can actually separate the motile fraction and then you can inseminate in the microfluidic device. So the company people itself is under doing some research on this. So they have to establish a protocol for IUI. Till that, we have to wait. So advantages, it mimics natural selection, rapid, very non-invasive, small volume of samples can be handled. But when it comes to large volume, you expect a more number of post-wash, it is not possible. It is very expensive and under research. So to conclude, we are trying to invent so many things since 1978, the birth of first IVF baby, since 2024. But the final decision maker in an IUI is the oocyte. So natural selection has to happen on its own. So thank you for giving me this opportunity.
Thank you. Thank you very much. That was an extensive talk on preparation of semen. And do you think definitely using the newer techniques would help us in an IUI? Because all of us long to get a pregnancy with IUI than shifting those patients for IVF.
Yes, ma'am.
Not yet.
We should not jump into the newer devices and use it for IUI, ma'am. Actually, when the company people itself, they are claiming that it can be used for an IUI. Only thing they are aiming at the post wash, but they are not worrying about the capacitation and acrosome reaction. So we have to wait for the studies to come up with IUI, then only we can use.
So still DG swim up is better for normo.
Density gradient. Yes, ma'am.
Understood. Any more questions?
So what do you use?
We've
Put it
had
on
a
the
lot
chat
of
box.
questions in the chat box, but Dr. Reshmi has been kind enough to reply all of them, all the questions. So they've been answered. So delegates can always go and look it up. It'll be good. And if you have any more questions for Dr. Anantalakshmi, you can ask her now.
So, Dr. Anandalakshmi, which method of sperm preparation have you found most useful?
Ma'am, it is not as such. We have compared with the direct swim up and density gradient. So we couldn't find any statistically difference between the methods. Actually, we tried when the patient comes for the first attempt, we'll try with the density gradient. Now, I'll try to change the preparation next time because madam will be trying to change the protocol. So I will be trying to change the methods. At least we can find out some difference like that. So when compared to the post-wash motile concentration, when compared to DG and pellet will give you a more number of motile spermatozoa compared to DG because we are separating in various gradients. We are using various gradients for separation. So coming to morphology, I also feel that DG will give you a good morphologically separated spermatozoa.
So our sometimes it's both in the same patient.
We have tried that also, ma'am. When we have large volume of semen sample, we will do that also, but we cannot inseminate both inside. We will get just, it can accommodate only 0.5 ml. So we have to paste that remaining sample or we have to concentrate and use.
We'll use only one sample, which is better of the two for insemination. Good. Anything more about letrozole protocol, Reshmi? They are talking about gaberlin to be added with letrozole for ovulation induction. Have you tried that?
Usually I do not gaberlin, but unless gaberlin I usually use for in an adenomyosis patient or an endometriosis patient. Those patients along with ovulation induction, we can, we give.
How much will you go in that case?
In that case, I usually give 0.25 mg twice weekly for around 8 weeks.
Okay. Now this they keep claiming that you can give one dose on day 3 and one dose on day 9 and then try. So that they say that you will have better ovulation with letrozole. And somebody was asking you about letrozole and multifollicular development. So you did mention about this escalating dose of letrozole, which is the most ideal. And the extended protocol is more ideal for PCOS because you want a single follicle and you can give it for a longer time because their cycles are always long. So the selection and things would take a longer period. So long extended protocols are always safe for PCOS. And when you want more number of follicles in a letrozole cycle, you'll have to try the escalating dose of letrozole. These two things I thought because I was traveling, I wasn't able to log on video. So I was not able to convey all these things when you spoke.
Thank you.
Thank you very much. Thank you. Any more questions? No.
We don't have any more in the chat box, ma'am. That's it for now.
Thank you. Okay. Thank you, Dr. Reshmi, and thank you, Dr. Anantalakshmi. Again, I should really mention here that they did accept my invitation to talk today in a very short notice. Thank you, Reshmi, for that. Thank you, Anantalakshmi, for that. We had a great time. And this is one of the most important or more practical thing that we would all do as gynecologists in level 1 centers. We all want to do ovulation induction. We all want to do step up to IUI. So that's the urge that each one of us have. So I thought this would be useful for everyone. Thank you very much. Thank you for being here.
Thank you.
And Sagiti, thank you very much for giving us the platform. And the meeting went on well, and thank you very much. Thank you, Gayatri, for being with us. Though I called her in the last minute because I was traveling, she did join in and do this for me. Thank you. Thank you very much.
Thank you.
Thank you, participants, for being with us till the end. Thank you.